My name is Dr. Aisha Rush. My Instagram handle is DRAISHARUSH. And today we are going to be doing a discussion of uterine fibroids. So, unfortunately, I gave a nice little spiel that nobody heard, and I apologize. I'm not quite sure what was going on with that. But needless to say, there were some sirens in the background and somebody ringing my buzzer and all that kind of stuff that you guys didn't want to hear anyway. But I am an OBGYN, and I actually practice in the state of New York. And uterine fibroids is a topic that a lot of women often have a lot of questions about. They have questions about why they're, how they're formed, where they come from, what are the risk factors, why exactly why are they the ones that ended up with them? Lots and lots of questions. So today we're going to be talking about number one are causes, symptoms that people may experience, and also treatment modalities. We're also going to be doing a question and answer session because I do know that there are a lot of questions surrounding uterine fibroids that women often have because it's just really a topic that a lot of people don't discuss very often. Many women will come into my office and say, I remember my mom having a surgery, and I think that she said that she had fibroids, but she never discussed that. I never knew what the surgery was for. I never knew what they did. But now I find myself in this situation, and I wish I would have had that discussion with my mom. So where do uterine fibroids come from? We don't know. And what are they? Uterine fibroids really are an overgrowth of the connective and muscular tissue of the uterus. Like I said before, the causes are really unknown. There is a genetic component that we think exists in that many women who experience uterine fibroids also have daughters that may experience the same thing. By the time a woman is 50 years old, up to 80% of women will actually have a uterine fibroid or more than one. And when looking at the incidence, ethnicity does play a role. In that, with fibroids, it's more common in Hispanic women, African American women, and least common in Asian women, and then Caucasian women fall somewhere in between. So when we look at patients with uterine fibroids, how do they present to the office? Many times women are going to present with a complaint of heavy menstrual bleeding, which is also called menorrhagia. Or they can come to the office complaining of pain. They may complain of intermenstrual bleeding, meaning bleeding in between periods. Or they may complain of some other abnormal uterine bleeding that cannot be explained by anything else. Or it can be explained by something else, but still in all, we have to do our workup. So what do we typically do? When women come into my office and they start to have complaints of intermenstrual bleeding, painful intercourse, painful periods, also just, any type of pelvic pain, the first thing that I'm going to do is likely do an ultrasound. Most OBGYNs are going to start with that. If it's something having to do with, intermenstrual bleeding, heavy uterine bleeding, stuff like that, then we may think about doing a hormone panel and looking at hormones as being an issue. Sometimes even the thyroid can cause menstrual irregularities and also heavy bleeding, or can cause patients not to have periods at all. So we will sometimes, depending on patient's complaint and what exactly is going on with the patient, we may decide to do hormonal workup as well. So where can these fibroids actually be located? Fibroids can actually be, most of them are going to be within the muscularis of the uterus. Some of them can be closer to the outside of the uterus. Some can be incorporated within the muscular portion of the uterus. And then some can also be connect not only in the muscular portion of the uterus, but also in connection with the endometrium. The endometrium is the lining of the uterus that we often shed when we have a period. Now, those are the fibroids that often cause us the most problems when it comes to patients with their bleeding. So then what exactly do we do when we have a patient who comes in with these complaints? We do an ultrasound and we see this distinct look of what appears to be a fibroid. Number one, what we're looking for is the location. Is this fibroid closer to the outside of the uterus? Is it within the muscularis of the uterus? Is it submucosal, meaning that it has some connection with the endometrium? Then we're looking at the size. We want to know how large this fibroid is. Sometimes, even not only doing an ultrasound, it's also very important for the physician to do a physical exam, because you can also feel these fibroids from time to time as nodularities or irregularities in the uterine sort of contour on the exam. And that can sometimes give us a clue as well as to where these fibroids are located. There are other places that fibroids can be located, but these are usually unusual places that we don't often see them, but they can actually exist, within the pelvic cavity, but not necessarily, directly always connected with the uterus. But again, those are very rare cases. So a lot of people often like to ask the question, well, are these cancerous? Many women will come into the office and they're afraid. They don't know what these are. A lot of times when it's described to them, it's described as a lump on the uterus or a bulge on the uterus, something weird that they, then come to me and try to describe. And then I kind of extrapolate from what they're talking about in their symptoms that they likely mean fibroids. So the majority of uterine fibroids are not cancerous. They are not things, that will lead to cancer. Now, can they be small when they're found initially and grow? Absolutely. Fibroids are often very vascular, meaning that when they do grow, they need a lot of blood to grow, but also they need estrogen to grow. They are fed by estrogen. So for many women who are young, when they develop fibroids, say for instance in their 30s, we know that the average age of menopause is 51. So when we're looking at a young woman who has a fibroid that may already be 2 to 3 centimeters, then we're worried about whether or not this thing is going to grow, especially if it's causing her problems. Some women will sometimes come in and complain of, feeling a bulge in the pelvis, feeling heavy in the pelvis, or feeling like they have a hard time defecating, meaning having bowel movements, like there's pressure there and they can't, or having urinary frequency. And sometimes these also can be symptoms of uterine fibroids as well. So then that's when it's really important for the physician to do a physical exam, because we need to know if there's a fibroid sort of on the back of the uterus that's causing problems with potential defecation, or if there's a fibroid closer to the bladder on the front side of the uterus, where it can be causing some pressure on the bladder and causing a woman to feel like she has to urinate frequently. Now, going back to cancer and no cancer. Again, many of these are not cancerous, but they can grow. Again, because they're fed by estrogen. Most women who are postmenopausal will sometimes see not only a slowing down of the growth or just no growth at all of the uterine fibroid or fibroids that they have, but they may also see a regression in the size of the uterine fibroid because they no longer have estrogen circulating in the amount that it was circulating prior to menopause. And so therefore, that fibroid is no longer being fed by that amount of estrogen. There is a very small subset of fibroids that can be cancerous. And most people will say, well, how do we know that? Well, the one thing that we look at as physicians when we evaluate patients for fibroids is we ask them, how long have you had these symptoms? Do you feel like, if they say, well, I've had this pressure or I've had this frequent urination, of course, there can be several things that cause frequent urination. So we have to go down the path of figuring out what other causes we need to look into, or potential causes we need to look into that could cause, frequent urination. But we then start wondering, okay, are the symptoms that the person's describing, are these things that have had a short onset and duration? Is this growing fast? Fast growing fibroids are a concern, and it is not something that we scoff about. These are going to be things that we watch very closely and do serial ultrasounds over a short interval of time. And now, what does a short interval of time mean? That doesn't necessarily mean weeks. We're not looking at weeks. Usually, this is a course of months. And so we have to make sure that we're following up with the patient appropriately over time, and also encouraging the patient to come back in to see us if, in fact, any of their symptoms change, or if or if another symptom develops. So now, looking at some of the things that fibroids cause, like heavy menstrual bleeding, what can we do? So when looking at fibroids and treatment, we're having to determine whether we are going to, whether this situation is going to be amenable to medical management, or if it needs to be surgical management that we move forward with. Being minimally invasive in the beginning is really important, if at all possible, meaning that medical management with medications, different things like IUDs for people who may have heavy bleeding with these things, those are going to be the first steps that most physicians are going to want to take. But of course, this may also mean that depending on the patient's situation, surgical management may be necessary before even, without even considering medical management, because that may be the situation that the patient finds themselves in. So what are the things that we're talking about in terms of medical management? So for patients who experience heavy menstrual bleeding or intermenstrual bleeding, things like progesterone-containing IUDs may be something that may be helpful for the patient. But patients have to be a candidate for that, in that we don't want to try to put in an IUD in a patient where we have a fibroid that's distorting the inside of the uterine cavity, because of course then that mode of treatment may not work, because we may not be able to put the IUD in the appropriate place. So that's one thing to think about and consider when thinking about placing IUDs. We need to know where that fibroid or fibroids are or is. The next thing is looking at medications that will help with heavy menstrual bleeding, such as tranexamic acid. That is one thing that some physicians will prescribe to women to help them with those early days of their periods, where they have that heavier bleeding to start. And usually with that medication, it is very helpful in trying to, helpful for women in terms of trying to sort of squelch that heavy bleeding from the beginning. Not completely take it away, of course, but to at least make it more manageable. Now, there are other things such as, oral contraceptives, some of the hormonal things that we sometimes will use to help regulate patients' periods where they're not having this intermenstrual bleeding that may occur. We can also give these things to patients who have heavy menstrual bleeding as well, to see if we can get their bleeding to sort of be a little lessened throughout the month. So there are different things that we can use, but the most important thing is having a dialogue with your physician about your symptoms. And what kind of things are we going to ask you about your symptoms? We're going to ask you the quality of any pain, the quality of any bleeding. We're going to ask you how long your cycles are, how long your bleeding lasts for your periods, that kind of thing. So when we ask about cycles, what are we really asking? We're asking from the start of one period to the start of a next period, how long that is, how many days are in between there. So really what that means is from the start of one period all the way up into the last day before the start of another period, that is your cycle. So most often the average cycle is about 28 days. So some cycles can be 45 days. Anything beyond that is abnormal. Some cycles can be 24 days. Anything shorter than that, most often, can be abnormal. So we're going to want to know that, because it also helps us to understand whether or not there's some type of hormonal imbalance, or if there's something else going on outside of an issue with fibroids, because there could be several things happening all at once to create a perfect storm, and we need to sort of tease it out and figure out what the issue is. And it may require treating several issues at once. The next thing is talking about pain. When does a pain occur? Does it occur with intercourse? If it does occur with intercourse, is it going to, is that pain with deep penetration? Is it, pain, in a certain position? If it's not with intercourse, is the pain, does it come and go? Is it more pronounced with your period? Does the pain happen when you're not on your period? Is it sharp? Is it dull? Is it constant? Those are the things that we're going to be asking, because it could also give us an idea that maybe it's not the fibroid that's causing the issue, but there could be other things such as endometriosis or vulvodynia or vaginismus, a whole plethora of things. A lot of people think that women's health is simple, and they think that, things that happen down in the pelvic area is simple. Oh, you have ovaries and you have a uterus and you have a vagina. But those are organs that are very complex, and a lot of things can happen that many women don't have any clue even exist. Just speaking about things like vulvodynia, women are like, what is that? I've never heard of that before. What is vaginismus? Never heard of that before either. How exactly, do you treat those things? They exist. A lot of other things exist. And I think another conversation that we're going to have that's also huge is talking about ovarian cysts, which is a whole world in and of itself. So looking at the patient, listening to what they're telling you as far as periods, what their complaints are, what their concerns are, and then talking about, any imaging that's necessary, any blood work that's necessary, looking at hormones. This is how we come up with a plan. And usually when I talk to patients about a plan, this is what do I call it? Shared decision making, meaning that I am here as a consultant. I am here to listen and to make sure we come up with what we believe to be the diagnosis, with gathering all of the information that we have, with the information that you've given, as well as information from any hormones or any blood tests or hormonal tests, and also looking at any imaging modalities, and then trying to figure out what steps are next. So then talking about different treatments. So what happens if someone fails medical management, meaning we've tried everything that we possibly could, for the most part, that was reasonable for the patient, as far as medications, maybe even hormonal things, maybe even IUDs, those kinds of things, maybe even trying, just progesterone, whatever the case may be. Then if patients are still having problems, then we start to discuss the potential for surgical management. Now, surgical management can mean a lot of things, and it can mean anywhere from what's called a uterine an embolization, meaning that we are going to seek the help, typically of an interventional radiologist who do these procedures, to go in and start to shut down some of the blood vessels and block the blood supply to some of the fibroids, so that we're decreasing their growth. Remember, as we spoke of previously, fibroids like estrogen, and they also like to create a large blood supply, because that's how they're fed. So if we go in and we try to shut down some of that blood supply, that can lead to them degenerating or shrinking. Actually, I should say shrinking, and sometimes degenerating, but sometimes degeneration can also have its own problems. And that would be a discussion for a whole nother day. But that is one of the risks associated with an embolization, because if they do degenerate, that in and of itself can cause pain for the patient over time. So that is something that as a physician, we do need to discuss with the patient so that they are making an informed decision, so that they understand the potential risks, benefits, complications, and alternatives to every mode of surgery. Now, other treatment modalities can be things like removing the fibroids. So this can be done laparoscopically if that is the mode that your surgeon is comfortable with, if the fibroids are in a location where they can be removed laparoscopically, or it can be done as an open case, meaning that we end up having to open the abdomen and actually visualize the uterus and take each of the fibroids out one by one. If there's more than one, or if there's a large one, then we take that out. Now, some people will likely ask, what is the biggest fibroid that you've ever taken out? And this is actually one of my surgical specialties, interestingly enough. And it is a surgery that I was trained very well in, and one that I enjoy doing. So a lot of people tend to come to me for what's called myomectomies. The other names that you are going to hear in terms of uterine fibroids that they may also be called are myomas or leiomyomas. So these are also names that your physician may use, or you may see on a piece of paper in an after visit summary with your physician, or if you're having surgery or some type of procedure, you may, have it on that paper listed as that. So myomectomy is basically going in, either doing it open through the abdomen or doing it laparoscopically to remove the fibroids. Now, there is a way to do it vaginally, but this is for those fibroids that are going to be in connection with that endometrium. Sometimes we can remove the fibroids. So with that being said, I think the last thing that I was saying was talking about surgical options and, looking at who is candidates for different types of surgery. So again, as I was mentioning, if a surgical option is what a physician and the patient decides to go with, again, fibroids, if they're wanting a myomectomy, that can be done laparoscopically. It could be done open, meaning that we can open the abdomen and do it that way. But again, if in fact a myomectomy is not what is necessary, or the patient prefers, and or patient has already gone through a myomectomy and they're just like, I'm at my wit's end, I want this over with, and a hysterectomy is necessary, then there's different modes of hysterectomy, and hysterectomies can be done in several ways, but it's going to depend on the location of the fibroid and the size. And so looking at those different elements, also wanting to determine whether or not the patient has had previous surgeries. Did the patient have a C-section before? Did the patient have any other, with a myomectomy? What was that myomectomy difficult? Could there be what we call adhesions, meaning that, there's scarring in the inside where, the uterus can be connected to bowel, or there can be, connections, to the bladder that may not be able to be taken down, appropriately unless we go inside and do an open case. All of those things play a role in how we determine if surgery is an option and which surgery is appropriate. There are some people that want robotic surgery. These things can be done robotically. Myomectomies, removing the myomas or the leiomyomas or the fibroids, can be done with the robot, and again, laparoscopically. Hysterectomies can be done with the robot, and hysterectomies can also be done vaginally. But again, with vaginal hysterectomies, it's really going to depend on the size. It's also going to depend on the location and whether or not a patient has had previous surgeries. And then finally, doing a hysterectomy open, meaning that meaning that we're going to be opening up the abdomen to take the uterus out is another option. Oh, and laparoscopically as well. There are different modes. I can go all day into my little surgical little talk about different modes of removing either fibroids or removing the uterus if that's what's necessary. But again, the most important thing is when you do speak with your physician, we want to know all of the information that you have surrounding whatever symptom that you've been experiencing, because even small details can make a big difference in how we work a patient up. Small details in terms of the quality of the pain, if the pain is associated with something else, if it's associated with frequent urination or feeling like there's a bulge in the pelvis or in the abdomen, or if there's pressure there, if there's pain with intercourse. All of those things are really important. If there's heavy bleeding at the start of a period, if the pain that they experience is associated more so with their period, and they don't have it any other time, or if the pain is still there, even despite their period. All of these things are going to be very, very important to discuss with your physician so that we can make sure that we're working you up appropriately and making sure that we are looking for the clues that are necessary to render a proper diagnosis. So I know that there are more people joining, and I know a lot of that has to do with the fact that I've had to log off a couple of times and log back on. So with that being said, I'm going to open the floor up to questions. I think that I've pretty much covered everything that I wanted to cover for the most part. I have a few little notes here, and I'm just going to look through those really quickly and just make sure. We've already talked about the different names that fibroids can be called. And again, like I said, they can be called leiomyomas or myomas, which is something that a name that your physician may use either, in discussion with you or on paperwork. We've talked about, non-cancerous, that most of them are. We've also talked about those that can be cancerous, very, very small, number. And sometimes even when we even when we actually do remove fibroids, sometimes we find ones that may be precancerous, and we have to then go down that path with the patient in terms of appropriate follow-up, and sending them to another specialist to make sure, that they are receiving the proper treatment following surgery. We've talked about the fact that up to 80% of women by the age of 50 can have either one or more fibroids, and the fact that they can be more prevalent in the Hispanic population, followed by African American, with Asian women being the least likely to suffer from fibroids, and Caucasian women being somewhere in between, those spectrums. We've talked about the fact that many of the fibroids, when people do have them, are found incidentally, meaning that most often patient will come in with some other complaint, and has nothing to do with their fibroids, but just because most often when there's a pelvic complaint, either with periods, pain, or anything like that, most of us OBGYNs are going to order an ultrasound, and then we'll, incidentally find that a patient has a fibroid. Then of course, it's our duty to let you know that, not to scare you, but just to let you know that it's there, so that if you have another ultrasound with another physician and they mention that to you, you can say, oh yeah, I went to another physician. I had that same fibroid a couple of years ago. It was 1 centimeter then, and the physician says, oh, it's 3 centimeters now. Are you having any symptoms? No, I'm fine. So we've talked about the fact that, they're fed by estrogen. And we've talked about the fact that premenopausal women can have growth of these fibroids over time. Some of them, cause problems as they grow. Some of them do not. Some women don't need to treat them. Some women do, depending on symptomology. And let's see, we've talked about some of the ways that women present to the doctor's office, in terms of, the type of complaints that they may have. And we find that they have that they have uterine fibroids, and this is something that could potentially be causing the problem. But again, it doesn't always mean that it's just the uterine fibroids that are causing the problem. It could be other things as well, and it could be multifactorial in terms of what's actually causing their symptoms. So with this being, all of that being said, I hope I've given a really good overview, despite our interruptions, of what we have been able to talk about as far as fibroids. Now, I'm going to open up the floor to questions. And I know some of these questions may be very personal. And if in fact you do have questions, again, please feel free to reach out to me on my Instagram page, Dr. Aisha Rush, DrAishaRush. And you can inbox me any questions, and I'm happy to answer questions, personal questions, if necessary, because I know some of this stuff can be a little sensitive to talk about and ask questions about in front of an audience. So with that being said, does anyone have any questions? Please feel free to go ahead and type in. So while people might be trying to figure out different questions that they may have along the way, on things that we've already we may have or may have not already discussed, if there's anything that needs to be clarified, please definitely let me know if there's any clarification that's needed as well. But essentially, I think that with uterine fibroids, it's really a good idea. Many women will say to me, and I think I may have said this in the last talk, and I'm not sure who heard it before the audio went out, but many women will come to the office and say, my mom had this surgery. I'm not quite sure what surgery she had, but I remember her saying something about fibroids or some growth on her uterus or something. Most often people will say some growth on her uterus or something like that. And she was having problems with her periods. And I'm not really sure if this is the same thing. I really wish I would have spoken with my mom. The one thing as women that's going to be very important for all of us is to create a dialogue and for us to be able to share and share alike. There are a lot of things that happen with the female body that many women don't even discuss, they don't understand. And a lot of times women feel so helpless because they feel like they're out there, on a limb by themselves and that nobody else experiences what they're experiencing. When in fact, there are so many women that experience some of the same things, that they actually may be experiencing. And, I think one thing that we talked about the last time were vaginal infections, such as recurrent yeast infections and recurrent bacterial vaginitis or vaginosis, whichever you want to call it. And a lot of women suffer from that, and they suffer silently. And even with this, one thing that a lot of women have a problem with when they come into the office is talking about sex. Well, that's what I'm there for. I'm there to talk about, the pain that they have with sex, or the pleasure they don't get with sex, or the pleasure that they do get with sex, and to, sort of explain that. But also these very intimate things about, I had a doctor tell me that I had some growth on my uterus and I'm really scared. I don't know if that means cancer. I don't know if that's normal. I don't know if that's abnormal. Having those conversations and being willing to open up and talk about it is really important, because we don't judge, at least as a physician. That's not my goal. My goal is to educate, and it is not to judge someone for what they know and what they don't know. That is why we have been trained in order to be able to talk to patients about their conditions so that they better understand their bodies and what's going on with their bodies and what they can do to help the situation. So judging a patient and making them feel like they should not have come to you with that particular issue is a problem. And I will encourage all women, if you do not feel that you have the connection or or can muster, the nerve to have the conversation with your physician, it may be that that relationship is not one that should continue. You want to find someone that you're comfortable with, that you're comfortable talking to, even friends. If you have friends that you're comfortable with, just throw it out there. Girl, I experienced this. Have you ever experienced that before? Having those conversations, and a friend can say, no, I haven't personally experienced that before, but I do know a girlfriend that had this issue, and this is what happened. So I think that, opening dialogue, having all of us come together and try to figure out how to have these talks and conversations is vital to our personal well-being, really. There's a lot of misconceptions. There's a lot of bad information out there, a lot of bad experiences that people talk about in terms of different types of treatments. But the reality is that we really don't know what happened with that patient in terms of what happened, in the doctor's office. We're just getting, part of the story. But the other thing is that women don't get the information from their physicians that they need to be able to explain things the way that they should. So a lot of times women will come to me with these words of, oh, they said I had a lump on my uterus, rather than, being able to say, oh, I think that they told me that I have, a fibroid, or a myoma, or whatever the case may be. So as a physician, it's also our duty to be able to explain to patients sort of what is happening, what these things are called, so they can actually have a conversation with another medical professional about what it is they found when they saw the patient. The other thing is ask questions. That is important. Asking questions is extremely important. It is not okay for a patient to feel like they cannot ask their physician questions. That's not how this works. We are here to answer your questions. And no question is a stupid question if we don't know the answer. And I tell my children that, and I tell my patients that all the time. And a lot of patients get really bashful and they say, I know this is probably a stupid question. No, it's not. If it's a question and you don't have the answer to it, it's never a stupid question. And I'm always willing to have that conversation. Things even as sensitive as patients saying to me, I've never had an orgasm before, or I don't think that I have. What does it feel like? That is a conversation. And that is something that I will talk about one of these days as well. And I may do that on my YouTube channel, which you can also find me at Dr. Aisha Rush on my YouTube channel. And then again on Instagram. I usually will put the videos both on Instagram and YouTube, but there are some videos that I will put on YouTube only because of the length of the videos. So that is a discussion as well. Many women come in and they're just like, oh, what does an orgasm feel like? If I wanted to, have an orgasm, how do I pleasure myself? What do I do? These are questions that I am happy to say some women have been brave enough to ask, and I commend them for that. But again, it is always important that when somebody diagnoses you with something, that you try to get as much information as you can. But the other important thing is trying to make sure you follow up like the physician suggests. I'll give you an example. There is a patient that the largest fibroid I've ever removed was the size of a basketball. This patient had been told years and years before that she had a fibroid. She wasn't quite sure what that was. And most of that really had to do with the fact that she had limited education, of course. But then she just didn't ask all of the right questions. And so with that being said, by the time she got to the hospital, she was septic. And why was she septic? Well, the fibroid had grown so large that it really outgrew its blood supply and it started to degenerate. And that degeneration ended up leading to seeding of her blood with different bacteria and stuff like that. Now, how does that happen? It's a long, long story. But needless to say, the woman became very sick and she needed this fibroid removed. By the time we got in there to remove this fibroid, with it being so large, it ended up being a surgery that lasted for hours. And did the patient pull through and make it? Absolutely. She did. Did she lose her uterus? Yes, because by the time we were able to dissect that fibroid out, what was left of her itty bitty little uterus was really nothing. So, but was she an older patient that, was beyond her childbearing? Yes. Some people, speaking of childbearing, may ask the question, well, what does that look like for me if I have fibroids? That is a big question, because it depends on where the fibroids are located. It depends on how large they are. It depends on what actually, if they are impeding your ability to become pregnant. It depends on whether or not once you get pregnant, it's going to cause problems. And most people will say, well, do I need to have this fibroid removed before I get pregnant? That too has a lot of factors that we have to look at, because we don't necessarily want women with large fibroids becoming pregnant, because we also understand that the uterus is going to grow with pregnancy. The other thing is we also know that the blood supply that the uterus is going to provide is going to go more to a placenta than it is going to go to a fibroid. So then what may happen is that fibroid may start to degenerate, because now the blood supply has shifted and women can have pain. And so now we have to worry about a pregnant woman and trying to control their pain during their pregnancy. Lots and lots of questions, lots of things surrounding this topic. I haven't seen very many questions come through, and I know there's probably, things that people will think about afterwards. And again, for those people who have just joined, please feel free to inbox me if you do, or what do the young people call it now, I guess, DM. So message me through Instagram, if you have any questions that you want answered, privately. I'm totally okay with doing that. So I think I pretty much touched on just about the general portions of this discussion with fibroids. There are so many other things that may be situational for person to person that we, may need to go through, at some other point, but we can definitely do that. So I have a question that's come up. Is it safe to use while pregnant? Yoni soap. Yoni soap. So it depends on what's in yoni soap and where you're putting the yoni soap. I know this is kind of off topic, but whatever questions that you guys have, I'll try to answer them. So if yoni soap is, I always look to things that are hypoallergenic, just because you don't want to throw off the pH balance in the vagina with things that have fragrances and a lot of, different additives. So you want to try to stay away from anything with, like I said, fragrances or a lot of additives that are not necessarily hypoallergenic. If you're using it on the outside and it does have that hypoallergenic component, I think it's fine. Now, using anything on the inside of the vagina, I usually discourage anyway. Depending on what it is, things like douching or, putting certain things in the vagina, that aren't medicated, trying to treat an infection or something like that, I usually have women stay away from, because it throws off the pH balance in the vagina. But yoni soap, if it's hypoallergenic, no, not a lot of fragrance and not a lot of additives, and you're using it on the outside, I think it's fine to use during pregnancy. Absolutely. I hope I answered that question okay. I do want to thank everybody sincerely for logging in tonight. I really do. And I really hope that this was very informative. I hope I answered some questions that people had. And I hope that this is something that allows you to be a beacon of information for your fellow, ladies out there that may not, know very much about this subject, but have questions about it. So the one thing that strengthens our communities is for us to share with one another what we know. Trying to promote good information and not misinformation. And of course, if you don't know, Dr. Google is scary. It can be. So be careful about Dr. Google, but always feel free to ask your OBGYN questions. That's what we're here for. And again, if you have questions for me, just DM me and I'll send you some answers. All right, guys. Again, Dr. Aisha Rush. I'm going to be signing off here. I hope you all have a great rest of your week. And we'll see each other next time. We'll talk. We'll figure out what the next topic is going to be. I think ovarian cysts, but we'll see. All right, guys. Let me know if there are other topics that you want me to discuss. You can always message me with those. You all take care. Have a good night. Bye-bye.